Hello, and welcome to this episode of In Discussion With from Medical Update Online. Today I'm talking to Daniel Hearsey about the removal of incorrect penicillin allergy labels. Please, could you start by introducing yourself?
My name's Daniel Hearsey. I'm one of the Advanced Clinical Specialist Pharmacists with a focus on antimicrobials based at the Royal Cornwall Hospital Trust in the southwest of England.
And could you give us a brief overview of your role, what your current job involves?
My role within the antibiotic pharmacy team is to work across the multidisciplinary teams, focusing on the antibiotic stewardship policy and ensuring the safe and effective prescribing of antimicrobials at the RCHT.
Now, you are the first author on a recent publication entitled The Removal of Incorrect Penicillin Allergy Labels in a UK Hospital. And this is what I'd like to explore a bit more today. So what's the problem? Why did you feel that this was worth doing?
So we know that penicillin allergy labels are overreported and generally erroneous. So what we want to do is help to improve patient care by helping patients remove those penicillin allergy labels to enable them to be able to take penicillin safely, therefore treat infections more effectively and reduce broad spectrum usage.
But how does someone acquire a penicillin allergy label if they're not actually allergic to penicillin?
So more likely they've had penicillin in the past. Usually it's acquired at childhood where they might experience a rash after having a course of penicillin. That might be because the bacterial or viral infection being managed with the antibiotic rather than the penicillin itself. Patients also misunderstand what an allergy is or a true allergy and therefore report intolerances such as nausea, vomiting, diarrhea or headaches as allergies, which then means they can't have penicillins for the future.
And do we know what proportion of the population is allergic to penicillin?
So the general population report about 10% of patients will report a penicillin allergy. For hospital inpatients, it's slightly higher, with patients reporting 15%. However, various sources don't have an exact figure, but it's reported that in the general population, less than 5% are truly allergic to penicillin.
Is so-called delabeling of penicillin allergy a task for allergists or for pharmacists?
Historically, it was a role for allergists to do. However, due to the number of patients reporting a penicillin allergy label now, and the clinical time available for allergists to undertake this work, it's just not feasible. So the British Society of Allergy and Clinical Immunology released guidelines recently in order to help devolve that process so that pharmacists, doctors can undertake this work. So again, empower non-allergists to complete penicillin allergy delabeling.
I see. Now I'd like to turn to the study itself. So what did you do? And what did you find?
So initially, we established a study management group in order to identify the intervention that we wanted to do, which was remove inappropriate penicillin allergy labels. So as a group, we came up with the intervention to highlight patients that had a penicillin allergy label and then test them in an appropriate way after taking a thorough drug allergy history. That allergy history would then allow us to risk assess the patient and then manage that allergy label appropriately and delabel if we felt comfortable and it was safe for the patient.
Could you explain just a bit more about the classification of patients? I noticed that they weren't just allergic or not allergic. There were other classifications in between.
So after taking that detailed allergy history, we were able then to classify whether patients had a high risk history of a true penicillin allergy or a low risk history of a penicillin allergy. Any high risk patients were not deemed appropriate for the study and therefore were excluded. And these patients would require patch testing before we undertake any other testing. We weren't able to do that within the study protocol. For the low risk patients, they were either subdivided into direct delabel or a direct drug provocation test. And that was depending on the manifestations of the allergy and whether we felt comfortable to directly delabel, so take that off, or the patient had to undergo a test before we were able to delabel them.
And could you just clarify, a high-risk patient, does that mean someone who is at high risk of having a genuine penicillin allergy?
Yeah, so from the history that we've managed to take from the patient, that it would indicate there's a high risk of it being a true penicillin allergy. Doesn't mean that it means that there is a true penicillin allergy. It just means that it needs further testing, as outlined, probably a skin patch test to confirm that, as it's not safe just to administer some penicillin or to take the label off directly.